Imagine you are standing on the overpass of one of the largest highways on the planet during rush hours. Below you, millions of cars pass every second. Informations, good, lives, pressures, destination, all rushing along asphalt lanes in a relentless, perfectly coordinated flow. If a single lane is blocked, the traffic of the entire city collapses. The superhighway exists inside you at this very millisecond, but it is not made asphalt. It's made of myelin, axons, and neurotransmitters. Ladies and gentlemen, the trigeminal system is the largest and most complex sensory pathway in your entire head. It is not just a nerve that transmits the sensitivity of a tough date. The trigeminal is a massive data highway, a high-speed fiber-optic cable that connects your stomatognatic system directly to the heart of your brainstem and cerebral cortex. The ask that I want you today is, what happens to the wiring of our brain when we, dental surgeons, alter the map of this highway without proper neurophysiological care? To understand the magnitude of this highway, you need to go down the microscopic level of the mouth. When looking at a tooth, traditional dentistry sees a rigid structure and a name of enamel and dentin cemented in bone. But biology sees a sensory device of mind-blowing spatial precision. Each tooth is in your mouth is suspended in its socket by a richly nerved and vascularized connective tissue, the periodontal ligament. Housed within it are hundreds of periodontal mechanoreceptors. These mechanoreceptors are not simple tactile receptors. They are aerospace-engineering-grade sensors. They can detect not just a tiny force of a touch, but the exact directional vectors of the load applied to touch ground. Every time you chop, these PMRS encode the spatial and temporal parameters of the force and send an instantaneous signal to central nervous system. Right alongside them, inside the most powerful muscle in the human body, the masseter and the temporalis. Muscle spindles are at work. These spindles monitor muscle length and straight velocity in real time. And here lies one of the greatest eccentricities of human neuroanatomy. While almost all sensory nerves in the body have their cells body located outside the central nervous system, in the dorsal root ganglions, the cells body of proprioceptive fibers of the masticatory muscle spindles, and the portion of the periodontal mechanoreceptors are located inside the central nervous system itself, in the mesocephalic trigeminal nucleus. Think about that. The writing that detected the position of your jaw and the pressure on your teeth has a direct line with no middleman connected deep into the brainstem. It's a priority express lane of data that constantly informs the brain. Where we are, how hard we are squeezing, and where we are going. Thus, uninterrupted stream of proprioceptive data enters the pons and distributes itself through the trigeminal sensory nuclear complex. Fine tato information and periodontal proprioception rush toward the principal sensory nucleus located rostrally. Meanwhile, pain and temperature signals travel down the spinal tract, reaching the subnucleus caudalis, also known as the medullary dorsal horn. But the brain does not just want to feel, it needs to act. To coordinate the miraculous act of chewing, which he queries your teeth to crush hard food without destroying your all periodontal structures or biting your tongue, for example. The brainstem utilizes an extraordinary neural networks called the central pattern generation, CPG. The CPG is the autopilot of your mastication. It determines the exact timing for the pressure muscle contract while the elevators relax, generating the physiological chewing cycle subconsciously. But the CPG's autopilot does not work in the dark. It is a closed-loop system. It fundamentally relies on continuous feedback and feed-forward provided by periodontal mechanoreceptors and muscle spindles. It's this trigeminal flow that warms the CPG, whether food is soft like a marshmallow or hard like a nut, allowing muscle force to be calibrated milliseconds by milliseconds, cycle by cycle. If the occlusal system is balanced, this trigeminal highway flows in silent harmony. The brain spends as little energy as possible, relying on automated subcortical reflex to manage the biomechanicals of mouth. But what has happened when we alter the design of the road? What are due to the loss of posterior teeth, the cementation of restoration with a microscopic premature contact, or orthodontic movement that creates a temporarily bite instability? The firing pattern of this highway changes instantaneously. When an acute occlusal alterations occurs, the periodontal mechanoreceptors send an error or overload signal to the central nervous system. The brain detects this mechanical instability not as a simple local event in the mouth, but as an imminent threat to the physical integrity of the skull. The cortical reaction is mediated. Functional magnetic resonance imaging fMRI studies show that introducing an occlusal alteration causes immediate and massive cortical activation in the primary somatosensory cortex, S1, primary motor cortex, M1, and the supplementary motor area, SMA, areas that previously processed showing at a low energy subconscious reflex level are now hijacked by the conscious cortex. The prefrontal and motor cortices must recruit hundreds of new voxels of neurological energy to try to map mechanical detour, altering the motor engram to avoid the harmful premature contact. The brain enters a state of somatosensory hypervigilance. This is why a patient who receives a right crown or undergoes abrupt orthodontic change often reports a disproportionate level of central discomfort. It is not physical, psychological complaint. It is the patient's primary motor connectome running on shear exhaustion to prevent the structural collapse of their owl mouth. The chronic loss this occlusal integrity imposes a devastating neurological toll on the human brain. When a patient loses their posterior teeth and is not properly rehabilitated, or when orthodontic or prosthetic treatment finishes a case with unstable occlusal contacts and severe force asymmetries, the trigeminal highway loses its primary sensors. A study by Kobayashi and colleagues in 2020 using fMRI compared dental elderly individuals with dental ones, with or without dentures. The images revealed that tooth loss and the resulting chronic reduction of periodontal afference cause a drastic drop in active within the primary sensory cortex, primary motor cortex, and thalamus, specifically the ventral posterior medial nucleus, the basal ganglia in putamen, and the insula. Without constant tactile feedback from the teeth, the brain's control loop collapses. The functional connections pathway between the somatosensory cortex and integration structures like the cerebellum and frontal lobe progressively weaken. And what happens when the brain tries to compensate for this chronic lack of biomechanical stability? It triggers its secretory system through central excitator effects. Pain and occlusal proprioceptive instability recruit the protective motor reflex, triggering protective co-contractions. The masseter and the temporalis muscle enter a state of chronic hypertonicity and spasm to shield the jaw from movements that might cause further painful mechanical impact. The patient develops clinchings, morning muscle fatigue, and cyclic muscle pain. Negligent occlusal management post-orthodontics or post-rehabilitation ultimately condemns the patient to a state of centrally mediated chronic suffering. But if the trigeminal highway can drive the brain into chaos through instability, it's also the way back to harmony. Herein lies the sublime power of trigeminal neuromodulation through precision occlusion. When we deliver a rigid stabilizing splint perfectly adjusted to provide simultaneous, homogeneous, bilateral contacts in centric relation, we are not just placing a protective piece of acrylic over the teeth. really, we are reprogramming the signal line of the Trigeminal Highway by restoring an ideal orthopedic stability in reversible manner. The splint instantaneously alters the proprioceptive input reaching the central nervous system. It sends a message of biomechanical safety to the brain. Longitudinal fMRI studies such as the one by he and colleagues in 2014 proved that after successful treatment with stabilizing splints that eliminate the discrepancy between centric relation and maximum intercuspation, clear functional and plastic recovery occurs in precentral cortex and the posterior insular cortex. Abnormal resting state neural activity is normalized, signalizing the end of the conscious motor alert state. The splint works by activating a peripheral negative feedback mechanism in the central nervous system, silent system have bruxism and calming the hyperactive of the elevator muscle. The trigeminal highways return to operating at its cruising speed silently, subcortically, and save biological energy. We must stop viewing the mouth merely as the end of an isolated biomechanical line. The mouth is the gateway to the densest central nervous system pathway in the entire body. Every occlusal adjustment you make in the clinic, every microscopic selective grading of a premonitory contact, every careful protective rehabilitation or orthodontic finishing is an act of peripheral functional neurosurgery. Dental occlusion is connectome engineering applied to oral biomechanics. When we master neurophysiology and understand the trigeminal nerve as the sublime highway that it is, we stop being mere tough mechanisms and become architects of our patient's neurological, cognitive, and neuromuscular stability. See you next time.